Doctor, today I would like to review the most common questions you answer when meeting patients pertaining to fat transfer. Would you briefly describe the fat transfer procedure and what it entails?
Basically, fat transfer is not a new phenomenon. We've been transferring fat as plastic surgeons for years, I'd say 20 or 30 years. You know, when I was training a long time ago, fat was used to correct deformity, such as after an accident. We would take fat from one area of the body, usually with a little piece of a skin attached to it, and transfer it to another area in hopes it would restore contours. Over the years, we've been trying to develop the process of transferring fat as a full graft that will survive and therefore allow us to use it in aesthetic operations where you're trying to create shapes and contours that are more attractive, that insinuate youth, that fill skin that has drooped, that develop areas that are desirable, you know, as far as looking more attractive. Recently, these techniques have achieved a high level of reliability where actually fat can be transferred and fat does survive. So the era of large volume fat transfer is definitely upon us. What I mean by that is taking large volumes such as a pint, 2 pints of fat from one area of the body, such as taking from Peter and giving it to Paul where you might want more fat. So this is the era, I would call this the era of reliable techniques in fat transfer. So what defines a reliable technique is this: how we get the fat, how we process the fat so it does survive, and how we deliver the fat to the area so that it survives. I want to use this metaphor. So I say to my patients when I see them in consultation, the consult is very similar to that of your gardener. So you're looking at your backyard and you want to have shrubs and grass and a whole different look to the yard. Well, if you have a good gardener, he's going to go and get good quality shrubs, he's going to handle them properly, transfer them properly to good soil, and know how to nourish them so you get good survival. In the same way, using the metaphor, we get good quality fat from areas of the body which has high blood supply. We handle it very gently and very elegantly with new techniques, which I'll talk about. We then process the fat. This is where you increase the survivability of the fat either by centrifuge or by washing it and getting pure fat without the contaminants associated with the process of getting the fat, such as blood, local anesthetic, or free fatty acids. Then you transfer this pure fat with another very sophisticated new technique to either the breast, the face, or the buttock and achieve new contours and shapes that will last. So with this technique, one could probably ensure in most patients at least 50 to 70% survival of fat, which is excellent. With that said, you understand that it may take a couple of times to achieve the total result, but each one's building on fat transfer that's going to last probably for the lifetime of the patient.
You mentioned the fat survival. Is there a way to determine a percentage of the fat, or in essence how much of the fat actually survives after the procedure?
Yeah, it's not absolute, but it is defined by the nutrition of the patient, which is the quality of the fat. I actually write books on fat. Brown Fat Revolution is all about how I feel that fat has different qualities, different blood supply, different fibrous character to it, which will determine how it stands up when you go to use it to create shapes and contours. So the quality of the fat, where it's taken from, whether it's a fat belly versus a knee, whether it's a flank versus a breast, also sets up the blood supply in that fat, determines how much of that will survive. How it's processed, the latest technology is such that we are able to, in a closed system that is the fat never sees air, take this fat, centrifuge it down, spin it down, so you end up with a test tube filled with pure fat, no contaminants. That's a high survival rate. And the way that you deliver the fat. So in the old days, we had different instruments where we either deliver boluses of fat, that's large pieces of fat, which of course didn't survive because the surface area to volume relationship was such that the internal aspect of the fat never got blood supply before the inflammatory process was set up, so the fat died. Nowadays, the fat comes through like linear, in a very linear fashion, deliver several different layers of fat, so the blood supply can get in very easily, and the fat will really survive, really contour well, become cohesive with the tissue, become cohesive with the breast, become cohesive with the buttocks, augment the cheek, augment the chin, become part of the body. So it's all part of the new technique. Horizon of the new technique is happening right as we speak.
I know this procedure is something that you've done hundreds and hundreds of times, but it is new to a lot of people, the actual layperson out there. And some of the questions that I've received being in this industry is it safe? What are these safety issues involved with transferring it, let's say a large volume, for an augmentation or breast augmentation?
Well, I think that some people's misconception about use of fat in breast augmentation is one that they would compete with each other. They're not competitive. So the patient who would want to have a breast augmentation, who would be best treated with an implant, is a very different patient than one who would be treated with fat transfer. Starting with safety, the American Society of Plastic Surgery set up a task force a couple of years ago to study the safety of fat transfer to the breast. In my history, I have a long history of treating patients with breast cancer, doing a lot of breast reconstruction. The last thing in the world I would ever want to do is to transfer anything that would confuse the issues as to detection or treatment of cancer of the breast. Our task force determined that when properly transferred, there is no increased risk of cancer, and when properly done mammograms in a center with qualified physicians reading them, that the use of mammograms is not confusing to these radiologists when fat is transferred, so it is safe. When is fat transfer most desirable? When is it best to use fat transfer versus a breast implant? If I have a patient who has a adequate sized breast, for instance, but the shelving is a little weak, or there's no cleavage line, or she wants a little oomph to her breast, well, a little bit of added volume in those specific zones is to give her that added attitude that she wants to her breast. It's not all about volume. So the other misconception people have is that breast is all about the cup size, the volume. It's not. There's a lot of characteristics of a breast that define the beauty and the attractiveness of a breast, which have nothing to do with the size of a breast. So a lot of these women do exist who don't need or want an implant, but do want a little more sexiness to their breast. You know, that's what the artistry of fat allows me to produce. A very common patient, I'm thinking of a few right now, is the older woman who may have a lot of arm fat, noticing that with menopause she deposits more fat in her arms working out at the gym. So you do liposuction of the arms, trim those in. At the same time, you bring that fat right over to the breast and let those breasts look more lifted. Augment the nipple, augment the shelving, augment the cleavage, so the complete line across the chest is improved. It's kind of magical in that case. Or the runner who really, really wants to look thin, who doesn't want to have breast implants, who really has lost all the fat in her breast, but wants a little bit of fill to her breast. Perfect candidate for lipotransfer to the breast.
This is probably the most frequently asked questions from patients, I would imagine. What if the patient gains or loses weight? What happens to the fat that has been transferred to the breast, for instance?
Yeah, a great question asked all the time. And the good news is fat behaves like where you took it from. So if you take fat from your belly and transfer it to the breast, it behaves like your belly. Good news, because it will augment the augment, as opposed to make some area look dysmorphic or out of character. So I don't see that as a negative. I think it's a gain-gain. Most women's bodies will deposit fat in a very sequential fashion, prioritized in areas, and it is advantageous to sort of take fat from the hog cell areas, which are not attractive, put those fat cells in the areas that are attractive, and then gain weight, and you still will have the same shape and contour that you had after surgery, but bigger.
Doctor, thank you for taking the time to answer these questions, and we look forward to hearing more about fat transfer to larger volumes such as the buttocks and other areas of the body in the next video. Thank you.